All right, good afternoon, OLLI at Berkeley, and welcome to our next installment of Your COVID Questions Answered with Dr. Deborah Gold. My name is Matt Shears. I'll be the host for today. I'm your curriculum coordinator at OLLI, and the title of today's meeting is the Tripledemic. But I wonder, Debbie, can you tell us what is this triple pandemic that people are talking about?
So it's ongoing COVID, but superimposed on that is RSV or Respiratory Syncytial Virus and influenza. So those three viruses are circulating right now, more RSV than influenza, and a fair amount of COVID is still circulating as well, and is anticipated to be going up as the weather gets colder.
So for these three diseases, is there a higher risk associated with having to combat all three?
So the issue is really what happens in the healthcare system, which is very much under stress right now, especially emergency rooms, especially pediatric emergency rooms, where they are being overwhelmed with kids coming in with RSV infection, but also some co-infections, and there's just not enough people working, not enough healthcare workers working, not enough pediatric hospital beds. I think as we move along into winter, we're going to see great stress on the adult side of the emergency rooms too, with increased hospitalizations and the consequences of that. So, stressing the system, stressing intensive care unit beds, etc.
Great. I should mention too, if questions do arise for you members of the audience as we're talking, you can put them in the chat and I will get to them. Dr. Gold, is RSV only a disease for kids? It seems like it's talked about much more often in terms of pediatrics.
Yeah.
Is there a risk for our group?
Yeah. So I have to say that during my career, I don't think I ever diagnosed RSV in an adult. Maybe I saw some people who had it, but because I didn't order the $300 respiratory pathogen panel, I never diagnosed it. But it can be serious in older people 65 and older. People with comorbidities are at higher risk. It just, and it can put you in the hospital. I think that maybe some of the pneumonias that I was treating, thinking they were bacterial, might have been RSV. And it's a little bit easier to diagnose it now compared to even when I was still in practice. So it definitely can affect people who are older and can cause disease severe enough to put you in the hospital. It's upper respiratory and then can also be lower respiratory.
Okay, great. We do have a couple of RSV specific questions, so we'll stick on this topic for a minute. For RSV, can you infect others before you display symptoms?
Oh, gosh. I do not know. And I've not seen any literature about that, at least recently. I have to say that RSV would not be something that I would pay a tremendous amount of attention to during my career, because we considered that a disease of children mostly. And I am not a pediatrician and never saw children. But I don't know if it is transmissible before a manifestation of symptoms. Many viral infections are, including COVID, and influenza is transmissible a day before the appearance of symptoms. So I wouldn't be surprised if it had that transmission pattern, but I don't know for sure.
Joan asks, is there a test for RSV?
There is. The upper respiratory secretions can be tested easily for RSV, and it's done all the time routinely in kids, and now probably increasingly in adults as well, who are presenting to emergency rooms or getting admitted to hospitals with respiratory infections.
Okay, here's another RSV question. If I'm concerned about immunity going forward, having recovered, will one be safe from RSV for the time being? Or there are different strains? Yeah.
For the time being, and that might be actually years, but it's really unknown what the durability of RSV immunity is. So I would say, you probably would not get infected with RSV in a year or two, or maybe even 3 years. But because it's unknown what that durability is, I'd say it might be an ongoing risk later. I have to say, I can't remember ever reading or seeing a paper about RSV in adults. I think there must be literature on that, but it never really caught my attention, and I have a particular interest in viral infections, so I have to plead ignorance on this one.
Okay. Larry asks, why would a lab not want to take a swab to test for it?
Because you might have evidence that you have something else. So RSV is an infection that in anybody out of infancy is not actionable. There's no antiviral that we use there. I think infants are sometimes given ribavirin if they are ill enough to come into the hospital. But ribavirin is a very broad spectrum antiviral. It is not used in adults. And so RSV it's not an actionable diagnosis, and it costs a fair amount of money. I think a respiratory viral panel costs about $300. It's not usually used in adults. We often can make a diagnosis from other means like blood cultures, sputum cultures. Sometimes there are characteristic patterns on chest X-ray that might suggest one pathogen over another. So I never made it a practice to look for pathogens for which I didn't have any treatment. I think the one reason to maybe know about RSV is that you have to take contact precautions and droplet precautions, and for many other pathogens you don't have to take contact precautions. But I have to say that, even having been a hospital epidemiologist, because we weren't diagnosing RSV in adults, we were only using droplet precautions as we would for a suspected viral infection, and we were not using contact precautions. So
okay. If we have other RSV questions, we can return to those later. We do have a couple of questions about the upcoming holidays, and that is one of the reasons why we thought having a talk with you would be good. Here's one. Is there a risk of attending an indoor holiday dinner with 16 adults and 4 children?
Yep. Yes, there is. So,
perhaps maybe it's
there is risk. There is clearly risk. Being indoors with people who don't have a mask on, who are, talking and maybe talking loudly because they're also drinking, and little kids. So there's definitely risk. You have to just assess what your tolerance for that risk is going to be. So kids can be carrying all sorts of viruses, not just COVID, not just RSV, not just influenza, but other viruses as well. And everything is transmissible in an indoor environment where the air exchanges are not going to be are not going to be happening at all as they would on an airplane or in a hospital. So there's definite risk to that, and it's there are some ways that you can reduce that risk. If you had the meal outside, that would reduce it a lot. If you asked people to test the day of the event, at least people who were infected with COVID wouldn't show up. If you ask people not to come if they have upper respiratory symptoms, that would help. Having everyone vaccinated and boosted will protect people from not progressing to severe disease, but will not prevent transmission of infection. So yeah, I mean, if you've listened to me talk before, you know that I'm quite conservative, so I would not be doing a Thanksgiving dinner with 16 people and 4 kids indoors. And right now we diagnosed my 97-year-old father with COVID yesterday. So it's, you know, when you're an older person who has comorbidities, even if you've been vaccinated and multiply boosted, having a COVID diagnosis is super serious, can be super serious. So my sister and I are just sort of watching, you know, and hoping that, you know, nothing is going to go wrong. In fact, I'm sitting here with my cell phone because I'm, you know, I'm worried I'm going to get called by somebody saying things are not going well all of a sudden.
So we do have a question from Jackie. This is about the holidays as well. So what about exposure to those who've not been vaccinated? A higher risk or no longer, given that those who are fully vaccinated still get COVID these days?
I think that kind of issue is leveling out. I was talking to every Friday. I have this Zoom with my infectious disease colleagues for the last 35 years, and one of them has a son and daughter-in-law who are anti-vaxxers, and so her son and daughter-in-law and her 2 grandsons are not vaccinated, and she still sees them, but she tries to see them in safer environments. They infected her with COVID. They infected her husband with COVID. You know, you could get COVID from anybody, including somebody who has been vaccinated or somebody who hasn't been vaccinated. So I think the distinction is not nearly as great now because there is just, yeah. And probably the unvaccinated person has been infected over these last 3 years, so does have some immunity. And it is just very rare to see an unvaccinated person who has not been infected already.
Paula asks, how protected are you from COVID if you are at Thanksgiving with someone who's being boosted today?
Okay. So when you take a vaccination, it takes about 2 weeks to achieve an antibody level that would be considered protective. However, these, you know, people who are being boosted have had multiple other vaccinations. So I suspect, although I don't know this to be true, I think that the immunity, that the boost that you get happens much faster than 2 weeks. That being said, if this is an older person or someone, you know, the older you are, the more this might be true, the less robust that reaction would be, and the longer it might take for it to happen. So somebody who gets boosted today is probably in 3 days going to have some level of antibody rise, but maybe not what you would see in a week or 10 days.
So Carrie asks, what are the reinfection rates for people who have COVID with and without vaccinations or boosters?
What are the infection rates? Reinfection rates. Okay, so the best protection against reinfection is to have had, well, the best protection against reinfection is wearing a mask and distancing, to tell you the truth, no matter what your vaccination or infection history is. But the best protection against developing significant disease with COVID is to have been vaccinated, boosted, and to have had natural infection on top of that. So that provides the best protection compared to someone who's not been vaccinated or infected. And the next would be someone who has been vaccinated and boosted but not infected. And after that would be somebody who has been infected but never vaccinated. And then, yeah. And so I think that having had a natural infection does confer some additional protection to someone who's been vaccinated and boosted. Not that you should get a natural infection because that is associated with all kinds of things that you really don't want to happen to you.
Okay, we have a question here about expiration dates on at-home COVID tests.
Yeah.
If they've expired, but the FDA extended it 3 months, I'm sorry, I have a test that expires on 8/15/22, but the FDA extended it 3 months to 11/15. Has there been another 3-month extension, or should I replace these tests?
If you look on the FDA website today, you might see some updated data about extending expiration dates. If you don't see that, the test is probably okay. But if it's a high value test, like you're going to go to Thanksgiving dinner with 16 people and 4 kids indoors, and you really can't, maybe with immunocompromised people, and you absolutely cannot have a false negative, I would use a test that has not expired. But you might, that there's probably, and I think there's ongoing updating of these expirations of these the expiration dates on these kits as we get farther and farther along. Some of these kits have just come to the market in the last year or so. The expiration, the expiration dates can be updated many times as time goes on.
Okay, we have a couple of questions. People have their kind of personal question. Here's Judith. She says, I'm 80 years old, tested positive for COVID on a PCR test on 9/29. Do I wait 2 or 3 months to get the bivalent vaccine, which I haven't gotten yet? My symptoms were mild. I took Paxlovid and haven't had another COVID infection that I know of, but I was advised that I can't take another PCR test for at least 3 months.
Correct. I would wait
I
would wait the 3 months before you take the bivalent booster, because your immune system has been revved up a lot by that natural infection. So I would wait until that effect is waning, and I'd wait the 90 days.
Okay, here's another example. Someone says, I had COVID with mild symptoms in September and took 1 day of Paxlovid, but quit after having what I thought were side effects, including lightheadedness. I now think that the side effects might have been unrelated. If I get COVID again, how helpful would my remaining 4 days of Paxlovid be?
If you get COVID again, you should take the 4 days, no question about it, and then get another 2 doses to complete the 5 days. There is some discussion right now about whether the duration of Paxlovid should be increased from the 5 days to try to prevent rebound phenomenon, which has been observed in, every time somebody famous gets COVID and then they take Paxlovid, if they get rebound, which is a return of symptoms after disappearance of symptoms, also a return of a positive test and potential to infect other people, that gets reported in the news. So Rochelle Walensky had it, Biden had it, et cetera. Anthony Fauci had it. So there's some question about whether maybe 5 days was not long enough and maybe it should be a longer course, and that's actually being studied right now. But we know that taking Paxlovid will still, even 5 days of Paxlovid will prevent you from getting into the getting hospitalized or dying from COVID. So you definitely should take it. And I wouldn't take any less than 5 days, because now the chatter is maybe the course should actually be prolonged.
Okay. Beth asks, is there information about long COVID in different variants? Are the newer, milder variants less likely to cause long COVID?
That's a really good question. And, long COVID is still pretty much a black box. And I should say that there is an NIH study of Paxlovid that is starting for people who have long COVID. I think that it will not show benefit just in my gut, just because of what Paxlovid does. But people who have long COVID are being actively studied at many sites in the United States, in addition to at the NIH. And it's a big basket of people who have had different variants of the virus, who have had different severity of illness, who have had that illness at different times, so that people who were like sick enough to get into ICU may have actually a completely different disease from people who had mild illness, but their symptoms at a year or at 6 months or at 2 years now can look very similar. So this is really just being sorted out now, and whether you can still get long COVID with these Omicron subvariants. I don't know. I don't have any information about BA.5 versus BQ.1.1 versus, BA.2.75. So I think that is information that's going to come eventually. I should say that there was a preprint from about 10 days ago out of Scripps. I think it was Scripps. Yeah. That looked at the effect of taking Paxlovid on the risk of development of long COVID. And taking Paxlovid decreased the risk of development of long COVID by 26%. This was a pretty small study. I think it was in the order of 250 patients who were followed prospectively. And those patients were not all from, this week. So they're spanning a period of time when there were some variants present, and then other times when other variants were present. But there is now this benefit of Paxlovid in decreasing the risk of long COVID in patients during the Omicron period, and perhaps before. I have not actually read this preprint in detail, so I can't remember how far back they went when they started to enroll patients.
Okay, Jackie asks, are the current home tests accurate for the new variants? I had heard they weren't and wondered where that would leave us in terms of false negatives in home tests before an event.
Well, I will say that I think that they are sensitive and will still pick up these new variants. However, as we've been going along and getting these different variants circulating, the home tests have been maybe losing a little bit of sensitivity as we've been going along. That is the reason that the current recommendation from CDC is that you can't just use one test to tell you if you're infected. So somebody who has no symptoms, if you, and so this is what I'm doing with my mother right now, who lives in the same house with my father who has COVID. I am going to test her 3 times in, about 2.5 days to be absolutely sure that she did not get infected. And she is being sequestered from him, so there's no chance of her being infected by him while he's sick. So I'm testing so the recommendation, if you have no symptoms and you want to be sure that you do not have COVID, you have to test 3 times. And if you have symptoms typical of COVID and your first test is negative, you have to test a second time. And because I have maybe some increased worry about the sensitivity, I would probably test 3 times. I have a sick husband at home and he's had his second negative test this morning, and I'm going to test him again tomorrow.
Okay, thank you. Anne asks, or says rather, I'm having a bad side effect from the Moderna bivalent vaccine, lymphocytic colitis. I also heard after the fact, Dr. Fauci saying not to get this vaccine as it had not been approved. My question is that vaccine still effective against COVID despite the side effect? And Fauci.
So the vaccine is actually, the vaccine is approved on the emergency use authorization that Moderna got for its original vaccine. So because the vaccine uses the same platform for its production, they didn't have, when they did a bivalent vaccine, they didn't have to seek another emergency use authorization for that particular vaccine. They did need to go before the advisory panel to the FDA and also to the CDC, because there had to be a recommendation about who was going to receive that vaccination, but they did not start from scratch with the FDA seeking approval. And it's very much like companies that make influenza vaccine. It's a new vaccine every year, but because they use the same platform every year to make their vaccine, they don't have to start from scratch again. They just they seek approval for this they seek a modification, or it's not a modification, but there's some approval method that happens for drugs that are very similar, that have to be tweaked a little bit every year. I would find it really hard to believe that the bivalent vaccine caused lymphocytic colitis. That just doesn't ring true to me. I follow the literature about this pretty closely. I've not seen anything about that. I suppose it might be worth sending in a report to a VAERS report. But it doesn't seem like something that would happen. I could be wrong about this, but I would be surprised if Food and Drug recognized that as a side effect of the bivalent vaccine. I think,
okay, oh, pardon. And
anyway, I just want to say one more. I just want to say one thing. When you have widespread use of a vaccination that's new, and this happened in 1976 when there was swine flu vaccine, and I think it was Gerald Ford had to make a decision about whether it was going to be a go that this vaccine was going to be used very widely. The insurance companies, because this was a new sort of novel influenza vaccine that was quite different from the prior, or was different significantly from the prior, the insurance companies they said, you have to indemnify us, because if we distribute 100 million doses of this vaccine very quickly across the United States, anybody who gets a heart attack within a week of that vaccine, that's going to be blamed on the vaccine. Anybody who gets basically anything within a few hours, days, or weeks of the vaccine, it's going to be blamed on the vaccine. And this is we're kind of in a similar situation where large numbers of people are getting a vaccine. And so anything that happens to them that might be even temporally close, or maybe not so close, it sort of gets tied to that vaccine. And oftentimes there's not really an association. You have to kind of see more cases of it in order for it to be compelling, to make a compelling story of cause and effect. Otherwise, it's true unrelated.
Okay, Anne does follow up. She does say that her doctor had confirmed there was at least one small study about this, but I think her question at this
okay.
point is the Moderna vaccine effective? Is it still effective?
Yes, and there have been papers posted about this quite recently, at least showing in the laboratory that people who have gotten the bivalent vaccine have increased antibody titers to BQ.1.1 to these other variants that are circulating now. So yes, it should be effective. Again, not for infection. These vaccines do not protect you from being infected. They do protect you from getting sick enough to be hospitalized or dying from the infection.
Okay, we're changing topic here a little bit. So Alan has asked a question that I've actually had myself. Is there any reason to wear a mask outdoors other than to keep your face warm or to hide your identity?
I don't wear a mask outdoors. And yeah, it's just like if I had to wear a mask outdoors, it would just make me absolutely crazy. So I don't. And so as I've said, if you've heard me do these Q&As before, we do have people come over for dinner. We eat out on our deck. We have a heater. We tell people to bring their down jackets, and we do, so we don't mask, we're eating, so I don't wear a mask outdoors. I think if I were at some, very crowded, I don't think I would go to a very crowded event, but if I were in a situation where I was in like just a huge mass of people outdoors, I probably would wear a mask. But we went to opera at the ballpark. We didn't wear masks. So yeah, no, I don't wear a mask outdoors. I think transmission of the virus outdoors is much more difficult, although the variants that we're dealing with now are more transmissible. They do have a transmission advantage over the priors. So maybe something is going to change, but at this point, I think it's I'm not wearing a mask outdoors.
Okay, Susan asks, a friend says that she got small fiber neuropathy and cryoglobulinemia from her first Pfizer booster 1 year ago. Is that possible?
Yes, I think that's possible. I do think that's possible. And I have read of other, I think that both of those have occurred after other kinds of vaccinations. So that's why I'm saying I think that's possible.
Okay, well, we are almost at the end of our questions. Oh, here's a couple more. Here we go. Ellen asks, since I got the flu vaccine and the latest COVID booster early in September, because I was going overseas, would it be possible and or advisable to get another COVID booster, say in late December or January?
So was the booster the bivalent booster, or was it the mother booster, the original? Because I think that I can't remember how long that bivalent booster's been around. I think it was around in September. So if it was the bivalent booster, I would not get another one.
Yes, she does say it is the bivalent.
The bivalent. No, I don't think that there would be a role for it, and I think they wouldn't give it to you anyway. But you can see how this model of having to take a booster every few months is not sustainable, and we desperately need to have a better way to protect ourselves against this virus, and that is going to be universal vaccine that will protect us against all coronaviruses, or taking a nasal vaccine that will stimulate local IgA production in the nose and upper airways that will be more effective in fighting the virus immediately once you breathe it in and it hits your mucosa, your nasal mucosa. So I think we're a ways away from having a better way that we just have to do something once a year. This is just not, it's not a sustainable model.
So this is a follow-up to the person who had the neuropathy and the cryoglobulinemia. The follow-up, Susan asks, is should her friend stop getting boosters then, given that this side effect happened?
That is a very hard question. I am not an expert in this area, but I will say one thing. I don't know if that phenomenon occurred as a result of taking an mRNA, if there's something about an mRNA vaccine specifically that might cause that to happen, and an immunologist would be a better person to address that issue. But we do have Novavax, which is a protein subunit vaccine. And so there is an alternative vaccine which could be used if there was some belief that it was that this reaction was somehow peculiar to having taken an mRNA vaccine. But I don't think I can comment just because I don't know enough about it. Yeah, sorry.
But it sounds like she should at least ask that question of somewhere
Yeah,
along the way.
I mean, yeah, because there is this other, Novavax, which is made exactly the same way as human papillomavirus or HPV vaccine. It's not, it is much closer to traditional vaccine production. Yeah, I guess I would ask about that if it could be beneficial to take that, or if that is gonna shake things up. It's possible there's some in vitro testing that might be done that could not at a local laboratory, but maybe blood could be sent to an academic laboratory that might be able to determine what exactly the antigenic insult was that triggered the cryoglobulinemia.
So about vaccines, Judith asks, or states rather, there's an Israeli nasal spray, Enovid, that suggests it kills 99% of the virus in the nose. Do you know anything about that?
I don't, and I don't know if that is a nasal spray like an antiseptic, but what I'm talking about is a nasal vaccine, and I don't know, maybe that's what that is. There are a number of nasal vaccines in the United States that are in clinical trials right now. In fact, there was one that was reported with the early reports were reported within the last month or so, showing negative results, that it was not effective in an early stage trial. But there are, I think, at least half a dozen other ones that are currently in clinical trials. And I'm so hoping that one of them is going to pan out, because I think that that's the only way I'm going to be able to start traveling again, is if I can get an effective nasal vaccine. There are also nasally administered nanobodies, which are they are very small versions of antibodies which are highly potent against SARS-CoV-2. And there is a lab at UCSF that developed some nanobodies. They selected out of like millions and millions of antibodies, nanobodies they were able to identify a mixture which they showed had excellent, incredibly potent activity against SARS-CoV-2. And they were looking for an angel investor maybe a year and a half ago. I don't know what has happened, but I thought, wow, that's an incredibly potent potential prophylactic tool where you could just apply these antibodies in your nose through a little little squirt bottle every morning, and that would protect you for the day. And then you just do it every day. And these could potentially even be over the counter. but I don't know what the status of the if that has even advanced to clinical trials yet.
So Nancy asks, could you advise about travel, both domestic and international? There are few, if any, masks on planes, and a lot of places there's no masking at all.
So the issue is not only that people on airplanes don't mask, but people get on airplanes who have COVID. And that happens all the time. A very close friend of mine's mother just died. And they held the funeral because one of the granddaughters was in Europe. And that granddaughter got COVID about a day before she was supposed to fly home early to go to the funeral. And of course, she got on that plane and so sat for 13 hours next to somebody who knows, so when you fly, you have to be aware that the person sitting next to you might have COVID. And people get on airplanes with COVID and they don't care, and they might or might not be wearing a mask. So if you have a low, if you can tolerate that kind of risk, then, go for it. But if you should just be aware that people don't wear masks and they get on planes with COVID. So I think it's risky. People go to, and the same thing in airports, people don't have masks on in airports anymore. And then where your destination is, depending on where you're going, if it's not like the San Francisco or Berkeley, maybe even, I can't even say about Berkeley, but in San Francisco, a lot of people are still wearing masks. But wherever your destination is, you may, people are not going to be masked, and even sick people are not going to be masked. So, yeah, so if you're going to get on an airplane, I think the way to make it the safest for you is, if you don't want to get infected, to wear an N95 or an N95 mask from door to door. So you have to keep that mask on when you leave the house, when you're in the airport, when you're boarding, through the whole flight, when you're deplaning, and then when you get into your transportation to get to your destination. It is a very hard thing to keep a good fitting N95 mask on. When I was working, I would find it very difficult to wear an N95 mask for more than an hour, and I've rarely had to use it for more than an hour. But I can't imagine wearing an N95 for 15 hours or whatever. But that is and that means that you can't eat or drink when you're on the plane, which is not a very good situation. So if you are going to wear an N95 or a KN95 and you do want to eat or drink, the least risky time to do that would be when nobody else is eating or drinking. So if the person next to you is having their meal, or everybody's having a meal, you have your meal after they are all finished having their meals, and then you take your mask off, and but there's not a, and then you have to assume that risk, I guess. So that increases your risk if you're going to eat and drink.
Okay, a couple of questions from Linda. She'd like to know, is it safe to do water aerobics in an indoor pool without wearing a mask?
Well, swimming pools are generally in very large, the venues usually very large. Even if it's indoors, it's not as safe as doing it outdoors. If there are windows or doors that could be left open, that would make it safer. But I can't imagine doing water aerobics with a mask on. So I guess, the risk is not, it's not zero, but if you can, distance yourself from people and have them keep doors and windows open, that would probably be sort of a relatively safe environment for exercise.
So Linda follows up and says the pool director claims that any COVID germs would fall into the chlorinated water and die. Does that make sense?
The ones that are droplet laden would, but what about the ones that are airborne? And those are the ones that we are worried about. So yes, that's true, but that does not take into account that we know that COVID is an airborne illness. And so those airborne particles will not fall into the chlorine laden water. And those are the ones that are responsible for most of the transmission of this infection. So, yeah.
Okay, and we do have some follow-up questions about travel. Karen says, travel sounds like Russian roulette right now. Why can't the airplane companies simply require a negative test before allowing people to fly?
Because if you require a negative test, then people are going to, it's not the airline. I mean, I think the government should so require it. I think that the airlines just, their interest is packing as many people into the airplane as possible, and not the safety of the passengers, not related to infection. So I think they just don't have any incentive. And I think airline travel would be safer if people had to test before getting onto the airplane. And it wouldn't be 100% by any means, but it would at least add a little bit of insurance to people who have some concern about getting infected, that they, if everybody has to produce a negative test, like at the airport, not 72 hours before getting onto the plane, but doing a rapid test, even a nucleic acid amplification test at the airport, it would reduce the risk. It would not make it a zero risk.
So Judith shares an interesting anecdote. She says, my son flew to South Korea a month or so ago. He was required to have a negative COVID test before flying on Korean Airlines, and masks were required. On arrival, all were subject to another COVID test. And if somebody tested positive for COVID, they were quarantined for a week on the COVID infected person's dime.
Oh,
it sounds like they've got it figured out.
I guess they do. Yes, they do. So, yeah. But I will say that, this thing about people getting on planes with COVID, it just blows my mind. My best friend and her husband went to a wedding in Alaska. They both got COVID at the wedding, of course. And they both got on the plane and flew back home with COVID on the plane. They're both physicians at an academic medical center, and they know better, but they did it. At least they wore N95s, but still, I would not want to have been sitting next to them with all that coughing for all those hours to get back home. So it is kind of Russian roulette. People who even should know better do it. I think weddings are really hazardous. Weddings are super hazardous.
So Larry asks, my daughter found out that she had COVID when she arrived at the airport from a trip. She was in France for 10 days. When do you think she might have contracted COVID? By the way, she got very sick and her husband never did test positive. So
it depends on when that was, if it was recently, and it was an Omicron subvariant. Some of the ones that are being transmitted now, I would say it was sometime within the 72 hours before the onset of symptoms. Wouldn't be unreasonable, but it's really not, you can never really pin it down. But because these highly transmissible variants are circulating, the incubation period can be shortened because you don't need quite as much virus to cause an infection.
Here's a good question. Susan wonders, are you eating indoors at restaurants?
Oh,
And/or how
no.
safe is that?
Oh,
Not you.
no, not. I would say not. Oh, by the way, so people who have COVID, who get on, people get on airplanes with COVID, people also go out to eat who have COVID. So they don't really care. Or they have COVID and they don't want to test because they don't want to know. So, people who are sick can also go out to eat. So I think being in a restaurant where the ventilation is poor to none, and where no one is wearing a mask, of course, because everyone's eating and drinking, and there's maybe alcohol, so people are talking even louder than they normally would. I think that's not safe. So I do occasionally eat at restaurants, but only in the parklet or in their outdoor tables. I've not eaten inside a restaurant for a very long time.
So this is a follow-up to the water aerobics question. Joanna says, how about indoor exercise classes at gyms if you're wearing a mask?
So again, I think it's really hard to wear an N95. An effective mask is very hard to wear during exercise. I can't actually imagine it. So I would say if you are able to exercise easily wearing a mask, it's probably not a good fitting N95 or KN95, because, when you are wearing a good fitting mask, it's kind of hard to breathe when you exert yourself. So I think that's, probably not the safest thing to do, but, you have to decide what your risk tolerance is going to be. Because, people who have COVID also go to the gym. They go everywhere.
So you mentioned risk tolerance, and Karen makes an observation here. Everyone has COVID fatigue and is tired of taking precautions and not living normally.
Yeah, I mean, I totally get that. But the more we learn about COVID, and this information, I think, just does not get into the general press as much as is warranted. But there are consequences to having COVID, and it's not only long COVID, which seems to be a lot more prevalent than was first thought. There's a recent French study showing that almost half of people who had COVID, and these are not people who were hospitalized with COVID, still have at least one symptom at 1 year. So, there can be persistence of symptoms, but I think this even scarier thing about COVID is that using the Veterans Administration database, and there's some other large databases that have reinforced this as well. Investigators have identified an increased risk for many, many things that persist for 12 months after having had COVID. So there's increased risk for all kinds of cardiovascular events: stroke, acute heart attack, congestive heart failure, arrhythmias, pulmonary embolus. I mean, just the list is so long. So that's just the cardiovascular risk. There's also risk for all kinds of gastrointestinal problems, for pulmonary problems, for genitourinary problems, you name it. I think the only organ system that I have not noticed where there are increased risk for appearance of new disease in all these organ systems is skin, but almost everything else: increased risk for Parkinson's disease, increased risk for dementia, increased risk for other kinds of sort of depression, anxiety related conditions. It's just like, whoa, I feel like sometimes I gotta stop reading stuff like this because it's super scary. And so when events happen, people don't even understand that maybe that's happening. Maybe that heart attack or maybe that stroke happened because you had COVID within the last year. And if you hadn't had COVID, maybe you would not have had that event, because the virus definitely confers a sort of instability in the human body in so many organ systems that can spell trouble later on.
Larry asks, do you want to mention the findings from the Virginia study of COVID reinfection?
Larry, you asked me about that email today or yesterday, right? Larry, why don't you, because you do it. Why don't you unmute him? It's Larry Bathgate. No. Oh, there you go. You're unmuted.
Yeah. Okay, what they found is that the people who have had COVID, whether or not they had gotten boosted, and this was a study of older, mostly men.
It was a VA study.
VA, yeah, not Virginia. And what they found out was that the result was that when they got COVID again, the second time, a lot of them got worse symptoms and results and sequelae than when they had their initial COVID, and then it increases after each reinfection until it reaches a plateau. So that's what I wrote to you about.
So, and anecdotally, early on, when it wasn't appreciated that you could get COVID multiple times, infectious disease doctors in New York, where there was that huge stress on the system early on, they were observing what they thought were reinfections in people who had maybe had a mild initial infection. The second infection might put them into the hospital and they might die from the second infection. So that these are VA data that suggest that phenomenon can happen, that you can have a worse episode from a reinfection compared to an earlier infection, even if and at that time there were no vaccinations, but even now with vaccinations and boosters, that can still happen. The VA database, which is millions and millions of veterans, has been what I call a treasure trove of data, which is being mined by a bunch of different academic medical centers, largely in the St. Louis area. St. Louis University and WashU St. Louis has been publishing a lot of papers looking at data that they have mined from the VA system.
Chet asks about the difference between COVID being causative and COVID being related to side effects. So he says, you alluded to this a bit earlier, the causation versus correlation question.
Side effects, you mean like long COVID or these other kinds of events that occur within the 12 months of having had COVID? So right now, causation hasn't been established because it really is unknown why it is that SARS-CoV-2 infection confers this increased risk and what the mechanism of the risk is. And so I think it's going to be a while before we understand how, like, for example, it's known right now that there can be an inflammatory process that goes on in the central nervous system following SARS-CoV-2, and that is probably responsible for neurological events that can be seen after SARS-CoV-2, but it isn't quite known how the virus actually induces that because there's no virus present in the central nervous system, yet there is this inflammatory response that happens there. And I'm sure that there are groups that are looking at all organ systems, looking for possible inflammatory triggers that can happen when the virus hits, and how that inflammation or other kind of change can result in adverse effects in that particular organ system. Again, even a year remote from the original infection.
So Joan would like us to return to the topic of RSV just briefly. She would like to know, how can you tell the difference between a cold and RSV in a young adult, and for how long would a young adult stay contagious even after symptoms have gone?
So I don't know how you could actually tell the difference. Again, as I said, I have not really followed the RSV literature very closely, other than, what's been going on right now, just because I never diagnosed RSV in an adult. I never, it's not actionable. There's not a way to there's no home test for RSV. And if you went to a physician as an otherwise healthy adult who was not in the hospital, you would not be tested for RSV. So I don't even know what the trajectory of viral shedding is with RSV in an otherwise healthy adult. I'm so sorry, I can't answer your question. It's just, again, it's not an actionable viral infection. So I'm sorry, I'm not able to answer the question.
Okay, everybody, so we are at the 2:00 hour. I have one final question here from Margaret, and then we can thank Dr. Gold for her time. Margaret asks, how long is Moderna bivalent booster good for?
So we don't really know. It looks like it's going to be on the order of months. And we have to wait and see how much viral infection is going to we have to look at what happens in hospitalizations and deaths this winter to understand how good this bivalent vaccine is. So that the experiments that are done in the laboratory looking at levels of antibodies not going to really be the whole story. So if we see a bump or a spike in hospitalizations and deaths this winter in individuals who have had the bivalent vaccine, then that will tell us that it's going to be on the order of weeks to months. I think, stay tuned, because that I think that's going to answer your question, and we don't know the answer to that yet.
Okay, well, Debbie, I think we are at the end of the hour here. Thank you for taking the time to talk with us and for sharing your COVID questions answered. And I'm sure we'll check in with you again soon. But thank you for joining us.
Okay.
And thank you,
Bye.
OLLI.